Welcome back to the Population Health Collaborative Conference. I'm Suzanne Lawson with Constellation Consulting, and we are the convener for the collaborative. As a reminder, this meeting is being recorded. Attendees' cameras and microphones are activated today. However, we do ask that you keep your microphones muted. Following each of today's presentations, we will have time for Q&A. You may ask your questions live or post your questions in the chat window. And you can just join the discussion online through our discussion forum at nmhealthequity.org/phc. Our next presentation today is from Duran Central Pharmacy's Stephanie Headrick. Stephanie is an almost native New Mexican. She moved to New Mexico at the age of 5 and grew up in several different small towns in New Mexico, thus giving her a front row view of healthcare, or lack thereof, in rural areas of our state. She attended the University of New Mexico College of Pharmacy and obtained her BS in pharmacy in 1992. While in pharmacy school, she answered a 2-inch ad for a pharmacy intern position posted on the bulletin board at the pharmacy school, and this began her journey at Duran Central Pharmacy. As of May, she has worked for Duran for 31 years, where she has seen pharmacy go from dispensing prescriptions to dispensing the knowledge that was taught in pharmacy school. The changes have been drastic but exciting, and she is grateful to work at a pharmacy where forward thinking is encouraged. Wellness and nutrition are passions for her, and she also spends time learning and educating her patients about the herbal supplements and homeopathics that have become a vital part of pharmacy. Please welcome Stephanie Headrick.
I'm going to unmute. Hi. So can I go ahead and share my screen?
Yes, please do.
Sorry, these are my challenges. I know it's here. There we go. All right. There we go. Sorry. We're going to go back to the beginning of my presentation. All right, and thank you so much for having me today. What we're going to do is we're discussing the pharmacist's role in reducing the burden of cardiovascular disease. And I'm going to be talking more broadly and then working my way down to our program that we've developed for the heart disease and stroke prevention program that we are currently contracted with the Department of Health. So I'm going to talk about what we do in our pharmacy through that program and some of our challenges, since it's a fledgling program to us, but it's really exciting to be working with you. So these are just some of the learning objectives that I'm going to let you just look at for a minute that we wanted to make sure that we emphasize within our program. All right. And then my presentation content is kind of an outline of what we're going to be doing. We're going to start with the higher numbers of the American Heart Association and CDC data for heart disease and stroke within the United States. Talk a little bit briefly about the modifiable risk factors for heart disease and stroke. Then we want to talk about pharmacists' impact on the heart disease and stroke prevention within the community pharmacy. Touching on the data as we move down to our state level from the Department of Health for heart disease and stroke in New Mexico, And then we'll just go start with an overview of our program and just talk a little bit more in depth about our program. And then some of our thoughts about potential improvement as we move along through this program, some of the things we learned as we started out and what we changed along the way, and just some potential impacts for healthcare providers working as a team with patient-centered care. So this is just statistics from the American Heart Association that again show, and I'm sure people know these, but it's always good to touch base again on them, that a heart attack occurs in the United States every 42 seconds, and a death from a heart attack occurs every minute, and a stroke occurs every 40 seconds, and death from stroke occurs every 4 minutes. So when you think about that, the impact is huge to have every healthcare provider able to work on these statistics and make them better. This slide comes from the National Center for Chronic Disease Prevention and Health Promotion, just giving some financial statistics about the cost of heart disease and stroke and just cardiovascular disease in the United States. So 1 in 3 deaths are contributed to cardiovascular disease, 214 billion in healthcare costs, and 138 billion just in lost productivity from the premature death due to the cardiovascular disease. And there's 108 million people with high blood pressure in our country today. And as we move to our statistics and in a couple of slides, you'll see that a third of people don't know that they have high blood pressure. So it's a large number of people at a higher risk for cardiovascular disease that don't know it. Just wanted to touch briefly on modifiable risk factors versus preventable or controllable risk factors. On the left-hand side of the screen, the lifestyle changes are modifiable risk factors that can be done. And as a pharmacist, I think sometimes we think that medication does everything, but the modifiable risk factors have to be addressed in any program that is going on with heart disease and stroke and prevention, because those are the cornerstones. So maintaining healthy weight, increasing physical activity, the well-balanced diet, salt, all of those modifiable, we'll want to talk to our patients about. We are also in that position, pharmacists uniquely, to talk to our patients about that. We have so much contact with them as they come in and pick up their prescriptions every month. So we can provide that lifestyle education, but we can also address the key factors on the right-hand column, and those controllable or preventable risk factors, including high blood pressure, high LDL cholesterol, diabetes, smoking, obesity. Within those, when you identify those, we can help by monitoring their blood pressure and cholesterol levels there in the pharmacy. We can have that patient discussion with healthcare professionals, talking to our patients, gathering that information and sharing it with other primary care providers. And also we can work with our patients to meet their blood pressure and cholesterol goals, encourage regular medical appointments as well as seeing us. And then we do a lot of medication adherence, because that has been shown to decrease those risk factors. And so just getting into a little bit the community pharmacy involvement in heart disease and stroke prevention, and really chronic care management. Pharmacy has gone so much from dispensing medication only to managing, in some cases, managing medications, but certainly being involved in many other things besides just dispensing. We are uniquely positioned to affect the outcomes for these patients. We are able to do point of care testing in our pharmacy, including blood pressure, cholesterol, hemoglobin A1C levels, and we also can then discuss with the patients their numbers. We can talk to them about medication adherence, about the importance of taking their medications, make sure that they're on the appropriate medications to reach their goals, and as well as then interacting with the team of the patient, the primary care providers and and pharmacists, to complete that triad of communication, which results in better outcomes for the patient. So we are able to assess the patients, we're able to educate them, and our ultimate goal with doing this is to help empower the patients to self-manage and understand what they're looking at, and to be able to make some changes and see what those changes are doing within their chronic conditions. These are just some of the impacts, and I want to go back to that slide of the 108 million people that have high blood pressure, and the 1 in 3 Americans that are not aware that they have it. So there's a lot of people out there that we can affect by creating community awareness about heart disease and stroke and the leading causes. So talking to our patients in the pharmacy as they get new medications, but just in general, talking to other patients as well. We can provide those patient care services that encourage lifestyle modification, referrals to other providers if we aren't the expert in a certain area like that, but we can encourage and teach self-management. Again, as I said before, we do have the ability to do point of care testing. So we do screening for uncontrolled and undiagnosed high blood pressure. We can do cholesterol screenings, and we, in our pharmacy, in collaboration with the University of New Mexico, the pharmacy school, we do atrial fibrillation screenings, and we included this, and we included in our heart disease and stroke prevention program, because there's a 5 times higher risk of a stroke if you have atrial fib and you don't know it. So we have a little testing that screens for that. And so we can refer our patients. We not only do it within our program, we also do it just as a screening in the pharmacy. Basically, those people that are going to our restaurant, they get stopped by our students and they have to do their AFib screening. So we have lots of ways of catching these people. We can provide patient counseling to patients who have poor medication adherence and help them find solutions. And I'll talk more when we get into our program, where we started from and how we work to do that. And then again, as my emphasis is participating in team-based patient-centered care. So always communication is key in our pharmacy. If we're doing prescriptions or we're doing programs, whatever we are, we believe in communication between the provider and pharmacist and the patient. And then just some benefits to pharmacist involvement in team-based care. There's been shown in studies that a team-based care approach can reduce the morbidity and mortality of patients with hypertension. And patients have shown greater medication adherence and greater satisfaction with care when a pharmacist is involved in their team-based care of their chronic conditions. And outcomes can improve when pharmacists are routinely helping screen patients for blood pressure control and medication adherence, because even patients that are compliant on their medications and pick them up every month may not be under control or on optimal therapy. So we can catch that if we have more involvement with programs like we're doing. And then just going from the United States data, this is the data that we pulled from the Department of Health. It was from 2016 and 2017. It was the New Mexico Department of Health data that showed that 30% of New Mexicans have hypertension, greater than 30% of New Mexicans have hyperlipidemia, and stroke has been the 5th leading cause of death in New Mexico up until then. Heart disease has been the leading cause of death in New Mexico, and 20% of all deaths in New Mexico are attributed to heart disease. So these initiatives that are that we're working with different departments to promote, and every healthcare provider could get on board, is so important to trying to change these numbers for our state itself. And Sometimes I feel like they seem a little overwhelming, but if everybody's on board and works in one way or another, these numbers, I feel like we could have a hand in decreasing these numbers. And then just to go into the broader picture of the New Mexico Department of Health's Heart Disease and Stroke Prevention Program, and then going into our program, which we are just one part of many providers that are working on this strategy. Really that center goal to improve the quality of care, to reduce the cardiovascular disease-related illness and save lives is the goal. We feel is the goal of the program overall. And all of the outside squares are what are going on in various areas of the state with different providers and health systems. So working with the various health systems, providers, and communities across the state, implementing and evaluating the effective strategies for cardiovascular disease prevention and management, and then using a comprehensive evidence-based approach to promote healthy lifestyle, and also then focusing on preventing, identifying, and controlling hypertension and hyperlipidemia. There's so many settings that providers of all walks can participate in various areas to bring it all together to meet in the center and really improve the quality of those chronic diseases and the patients' lives that are suffering from these diseases. And now just to take one step more, that just wasn't grammar, one step closer to our program. So we, just to tell you a little bit about Duran's, we decided about 5 years ago to implement a synchronization program. So this is kind of our stepped approach. We initiated it so we would sync all the patients' medications to get them all in the same day. And there were some reasons for it. One was we became very proactive in starting the patient's refills ahead of time. It was appointment-based when it was a smaller number of people, but we would get their medication synced, but it made it where our inventory was tighter, but we also were able to monitor our patients better for adherence, and realized that this was a great program. And we've, since it's been about 5 years, we are getting really close to 100% synchronization for our patients on chronic care medications. And that in itself helps us to keep our hands on patients who might be struggling with adherence. We then implemented medication or adherence packaging. A couple of years ago, we purchased a machine that does strip packaging so patients, I'll show you a demo, patients will get their medications in each, and it has the day and the time. This is my candy supply, but I'm trying not to eat it, but it tells you the date and the time and the medications that are in there, and it all comes together, and we coordinate this and get counts. So technically we know when they're out, but they know if they've forgotten a dose because it shows. So this has been in the last couple of years that we've started putting our patients on there, and as another step for adherence and helping our patients to take their medications appropriately. And then in late 2020, last year, the year that everything happens, we were approached by the New Mexico Department of Health. And we started out doing the diabetes prevention program. And from there, we were approached to see if we wanted to participate in the heart disease and stroke prevention program within the pharmacy, and doing the section of doing medication therapy management and measuring blood pressure and cholesterol. So we never do things half at Duran's. We said, yes, we want to do this. This is great. This is something that we can, we're already seeing, we're already doing adherence. And so we jumped in, and even though we had to survive COVID, we were proud of ourselves, because even it's fledgling, because this is our first year, we were able to implement the program. We were able to start enrolling patients, and we are getting there. So we can only see that we're gonna move forward next year, this next fiscal year with much better results, but we were glad to get it started amidst trying to vaccinate everybody and test everybody. So with that in mind, I'm just going to talk a little bit more in depth about our program and what we do. We start the process looking at our sync patients, and we are looking at those who are taking blood pressure and cholesterol medications. We are identifying them specifically because we know that they have a higher risk for development of heart disease. But we also feel the importance of providing additional resources, including lifestyle counseling, additional screening, medication adherence assessments, and then collaborating with the patient and the healthcare team. We do offer them a blood pressure cuff for home monitoring, and we teach them how to use it appropriately. And this program right now, we have a duration of 6 months where the patient's being seen at least monthly in our pharmacy while they're picking up their medications. So they can't really get away from us. So I'm just going to talk, this is our recruitment of patients. And what we did, we decided at the beginning that we were going to look at our patients because our patients are almost 100% synced. You know, we would think that everybody was very adherent to their medications, and yet it is that we still have that group of patients who we know we're targeting non-adherence because they either pick up their monthly meds late, so they're picking them up after the date that we know they should be out according to their counts, or they come to the window and they go, I don't need that metformin, I've got a bunch at home. And that's a red flag for us because we know that something's going on. So initially, before we started doing the heart disease and stroke prevention program, that was the cue to talk to our patients about what might be happening. Now we try and enroll them in our program. The other thing that we realized, though, is we went ahead and opened it up to everybody. And what we discovered was that we have signed up some patients on our program that are very compliant with their medication, and yet they still aren't at their goals because maybe their optimal therapy has not been used. And so so those patients still need our help. And so we communicate with the physicians about that. So it was good that we opened it up to more than just non-compliant patients. But we target those patients specifically on high blood pressure and high cholesterol meds. Then we're going to contact them by phone, or if they're picking up, we'll talk to them in person about our program, tell them about it and what it would entail. And then if they express interest, we're going to go ahead and sign them up and schedule their first initial appointment, either with the pharmacist. We have 3 pharmacists on hand that are working on this program. So just an overview of our program. I'm just going to go a little more in depth. At our initial visit and PCP initial contact, we actually have a consent form that they have to sign, and we have a excuse me, we have a form that they have to fill out that is an intake form. So it basically, we're gathering social history, we're gathering all of that, their medication history, their disease states, to have a complete picture, medications that they're on, and any herbals, any over-the-counter products that sometimes they forget to share with their providers, but we want to make sure that there's no interactions with that. We do a complete med therapy review, and we do a complete medication adherence review to make sure that starting off that they don't have any duplicate therapy, that they don't have any of that sort of thing. And then we move on to gathering baseline data. So we gather their weight, their blood pressure, their cholesterol. We do a cholesterol test, and we do their AFib screening. And so we have all of that information. We calculate their BMI, we calculate their 10-year risk for heart disease according to all their numbers. And then after we do that, we're going to provide them with a home blood pressure monitor. We're going to teach them how to do it appropriately. And then each and every patient, we're going to discuss their individual goals, because everybody has their own. Some might want to lose weight. Some want, we absolutely educate them on what their goals of their numbers should be, but we want to know what we're going to be targeting each month that we see them, because we're going to document those goals and we're going to go back to them each month when they come in. So we do that, and then we provide them with lifestyle modification training depending on what their intake form is. We have referrals for smoking cessation if they smoke and are ready to quit, and various other areas, and talk to them about exercise, stress management, sleep, how important sleep is, all of those things. So we're trying to make it a very full program. And I know that's a lot of, we've discovered that's a lot of information to gather from and provide to that patient. So we definitely want to have documentation, and that's been our biggest thing, because pharmacists tend to go on the fly and we write things down on sticky notes, and that doesn't go. So we're working really hard on trying to find a place to document everything, but we're keeping it all documented so that we can come back the next month and do it again. But we provide them with just some educational materials, and we provide them with a log, because we want them, part of our program is we want them to do their daily blood pressure logs. And so that we can look at them monthly to see what they're like at home, because sometimes they're very different than when you're at a provider's office. So that's our initial visit. It takes about 45 minutes to an hour for us to do this. After the patient goes, we write up an initial letter to the doctor saying that the patient is enrolled. We give the doctor some basic information about our program, and anything that we discussed with the patient that day, that goes off immediately to their primary care physician. And then a week later, we try not to make any recommendations to the physician about changes to medication or anything we see, unless there might be an omission, because we want the patient to get some home blood pressure readings. We want to see what that looks like when they're not stressed or in our office, just to see if there really is a need to make any recommendations. But a week later, we're going to follow up with the patient and talk to them about any questions they might have. Go follow and make sure that they're doing it, they're understanding how to take their blood pressure and get some of those numbers. And then we'll follow up with our PCP if we think that there's anything that we should be making recommendations about. And always, again, communication. If we are going to call their doctor about something, we'd let the patient know. When we hear back from the primary care provider, we're going to let the patient know. Any interaction goes to all three of us, so that we're all on the same page. And then monthly follow-ups, we try to align them with their picking up of their medications, because we feel like that's a great time for us to connect back with them. So we'll do a monthly blood pressure check. We'll revisit any of their goals that they want to see what they've done, or what they've accomplished, or what they need from us. And then at 6 months, we'll do a end of participation. However, even though at 6 months, if they still want to participate or they need more from us, of course, we're going to still be there for them. So that's kind of an overview of our 6-month program right now. We've tweaked it. We've had some changes. We've had some aha moments. Just a couple of those aha moments is we had a patient whom we asked to write down his blood pressure, and he didn't write it down. He didn't want to give it to us. He didn't want to do that. And what we finally discovered is this patient couldn't write. And so being in closer contact with those patients, you realize that you have to work individually with each patient, and there are things that you have to figure out along the way. But doing that, he has a phone with a camera. We had him start taking pictures of it, so he didn't have to write it down, and we could do that. So we're working with them to work around some of those things, but it's a work in progress for us as well as for the patients. But we are also gathering data for the CDC and for the Department of Health, and we are gathering information back from the patients about what they like about the program, what we can do differently. So this first year has been all about a learning experience, ramping up and really refining our program for future years. So So just to wrap up, just to go through again, our program activities, the requirements for our patients are the daily blood pressure reading at home, recording their daily blood pressure in the log that we give them, just taking a weekly weight measurement, and then goal accountability. So we write down the goals for them and we keep them so that we can touch base with them. And then we do that monthly check-in with home logs and an on-site blood pressure reading. And then we really look at medication adherence and medication therapy, and again, looking for optimal therapy with least amount of side effects so that they are willing to keep on their medication. Our activities on the other side of the coin are that we complete that medication therapy review. We do that medication adherence assessment, and we work with them. If they're not on our sync program, which again, most of them are, then we're going to put them on our synchronization program and offer adherence packaging if they would like it. We provide those educational materials and blood pressure log. We initiate that PCP contact and follow up if we need to during the month, or new meds, whatever happens to be. And then we coordinate that monthly visit and follow-up appointments. And then of course we're keeping our documentation to report our data for this program to the Department of Health and the CDC. And then just a little bit we want to put in there, part of why we started doing our sync program too is because the pharmacy, the insurance companies, especially Medicare, Medicaid, CMS, put in things that started holding insurance companies and accountable for outcomes-based therapy, outcomes-based rather than just service-based. And so it's not only pharmacies, but it's providers now, especially Medicare. And so for us, we have to strive. We have, it's called a star ratings program, and they're looking at our specifically chronic care patients for diabetes, blood pressure, and for cholesterol, and whether they're taking their medications and they're getting refilled. They call it percent days covered. They're also looking at high-risk medications on the VIRS list, statin therapy for diabetes. So they're looking at all of this, and pharmacists who don't have their patients that are all doing this, or majority of them, there's financial repercussions for us with prescriptions. So we decided we were gonna do everything we could on our end, but to also realize that on the provider side of it, Medicare is now having more outcomes-based requirements, including some med management, again, with some of those chronic diseases. And one area that pharmacists and other states, not so much here yet, are doing are annual wellness visits for Medicare patients, are a part of the what they're looking at for Medicare, Medicaid for those higher performing physicians or providers. And those are things that we look at as far as possibly, doing that and going into a physician's office. As we move forward with doing this med management, we feel like that would be another area. But just talking a little bit, because there are now, financial repercussions to not having good outcomes for your patients, especially in these 3 chronic diseases. And then just, we looked at, again, areas for improvement. The one place that we realized we were lacking after we had started this program is we really had to go back and educate our whole pharmacy staff on what we were doing. Because if one of us wasn't there and a patient called or came in for their medication, nobody knew what to do with them. And so we have since one-on-one talked to all of our technicians, our interns, our students about our program, so that for patient recruitment, and then for consistent targeting of those patients and knowing which patients are on the program and what to do if they come in. We learned really quickly that the more education we gave our staff, the better the program flowed and worked. And then just trying to find the best way for patient follow-up for monthly appointments if they're not picking up their med on that day, and following up. We really are still working on improving our follow-up with our physicians, with our patients, and that will continue to be a work in progress, but follow-up is so important to keep the program going. And then just some of the things that we're looking forward to in the future for this program and other programs hopefully to follow are, we're going to look at our outcomes for the targeted education for our pharmacy staff members to make sure everybody's doing what they're supposed to be doing. We'll continue working, targeting our patients through the medication therapy management programs and outcomes platforms that we have to do for those Medicare patients. We will refine our recruitment materials to make it more intuitive for the patients to understand the program. And then we are going to add a diabetes component starting in July to this program. So we'll be looking at that triad of diabetes, high blood pressure, and cholesterol, which goes together so much here in our state especially. And then just constantly improving that communication with the providers, not only regarding the heart disease and stroke prevention program, but the fact that a community pharmacy can be such a vital part of the patient care team. And then we'll continue gathering provider and patient feedback. And we are still looking for a good documentation platform that is easier to use and has data sharing with providers, which would make it so much easier to communicate. And that really is what I have to offer for our program. We're very excited as pharmacists to be able to do this. What our goal is to really refine this to the point where it could be duplicated in other pharmacies. Again, understanding the rural areas in our state, sometimes a pharmacy is the only healthcare provider within miles of patients. And it would be really nice if everybody was able to do this, and it would make a difference in the outcomes for our patients for these chronic diseases. So really appreciate you letting me present this today. And if you have any questions, I'm happy to try and answer them for you.
Great. Thanks so much, Stephanie. And as she mentioned, if you have any questions, please feel free to put those in the chat, or we'll give you a moment to unmute yourself too if you have any questions. And I know that it looks like Tasia is on as well. Did I say that? Did I say her name right?
Yeah.
Okay, so she is on as well, and so she said that she could answer questions. So go ahead and feel free to unmute yourself as well. So Wayne actually had a couple of questions. So and I think that she's trying to answer those in the chat too. So the questions are: does the log include lifestyle info in addition to BP measures? And then in addition to that, he says walking and/or exercise, sodium reduction, weight reduction when needed, etc.
So our log right now is just weight and blood pressure. We do encourage them to, when we look at their goal, if their goal is more exercise, or if their goal is weight reduction, or if it's changing your diet, we do encourage them to document that as well. We don't provide them specifically with a log right now, but we do absolutely document that those are their goals, encourage them to, that documenting, especially, what you eat or how many minutes is really self-empowering to do, because when you do it, then you have that log. But it would be good to provide them with that, just to make one less thing that they had to find. Or they may be the sticky note people too, and their sticky notes are all over as well. But yeah, Wayne, that would be something that we would definitely should do if those are their goals and those are things they're going to work towards.
Great, thanks. And then another question that Wayne had is, what if a patient receives some meds via Duran, but others through a mail service like Express Scripts?
Love mail order pharmacy. Don't get me started, Wayne. So at the point that we meet with them, we feel like at Duran's that we have a good rapport with our patients, and we can ask them. They will usually provide us a complete med list, and that's one of the things that we do before we actually do med therapy management. Now, for us, depending on if they're Medicare, there are platforms that medication therapy management platforms called Outcomes or Marixa that actually put out there what that we have to do certain med therapy management or complete medication reviews once a year, and we can look at all their medications, whether they get them from us or whether they get them from mail order. But we feel like we're pretty confident that our patients are pretty open and honest with us about the medications that they take. And we do ask them, can you please bring us a complete med list, so that we have that to work with before we start them on the program.
Thanks. One question that I had, we obviously have a variety of Department of Health contractors as well as health system professionals here. What can we do to support pharmacist engagement to further our work to reduce the burden of cardiovascular disease in the state?
Well, one thing that really helped us was being able to have some financial incentive to work with you. It helps because we can do all of this, but even though last year we were designated as providers under New Mexico law, so we should be able to be billing for these services through the medical part of it, we're still fighting to get that recognition and figure out how we're supposed to do that. But to support us, like the Department of Health has supported Duran's, and it's been really, really awesome that we've been able to do that, because it does make it much easier to develop those programs. You know, if you have a little buffer there to spend the time to really do it. And if there's providers on, just feedback on what the best form of communication, because we do send things over and we try not to burden the providers, because I know they see a bunch of prescription refills and a bunch of communication, but if we could figure out the best way to communicate with providers to, you know, for that, to have that patient care team, any feedback or any information that would help us would be so valuable to us.
Okay, thank you. Just give it a couple of seconds to see if there were any other questions. And there's a couple of comments coming in through the chat. It says, thanks, Stephanie, excellent presentation, great job. So, so I think that's it for today. So thanks so much, Stephanie and Tasia, for coming on and helping us out.
Yeah, absolutely.
And before we go into break, if our attendees can please complete the poll that has popped up for you, we would appreciate it. This poll is just a few questions and it's anonymous, and it'll help us in our QI efforts. So we will now break until 3:15 when Dana Bloomquist of CWA Strategic and Lindsay McIntosh of Workshop Wizard will present an overview of Path to Health and utilizing Workshop Wizard. This Zoom will stay live during the break.